Okay, I think we're going to go ahead and get started with the afternoon session. We've heard this morning about abdominal manifestations and about the brain and spine manifestations, VHL. Now we're going to switch gears a little bit and talk about ophthalmologic manifestations. So this is Dr. Darius Moshfeghi. He's been here at Stanford, I don't know how long, 20 years. And he's very, very experienced with management of ocular disease and VHL patients. He's pretty much who I send all my patients to, that VHL. And he's going to give us a overview of the diagnosis and management of ocular disorders in VHL patients. Darius?
Thank you, Steve. Make sure that you guys can hear me. First of all, it's great to be here. Can you guys hear me all right? A little louder? Maybe I'll just hold it like this. Okay. Yeah, well, the tie, Lord knows. So as Steve mentioned, I'll be speaking on diagnosis and management of ocular manifestations of von Hippel-Lindau. Pretty standard for the course. I have many financial disclosures. None of them are relevant to this topic, but they kind of pertain from the perspective that they work on pediatric retina screening, which is something I'm a big advocate for. The overview here is we're just going to talk a little bit about the epidemiology and background of ocular disease, how the eye plays a central role in VHL, pathology, what the pathogenesis and ocular manifestations, prevention and screening mechanisms, and then how do we actually manage this? And it's kind of a tricky situation because by the time you become symptomatic in the eye, we're way behind on where the pathology is. And it becomes much more difficult to treat, which is why the onus is on screening to make sure that we identify the lesions when they're small and easier to treat, if you will. Now, I'm going to be squinting because I left my reading glasses in the car and I don't have a big screen in front of me, and I'm looking at this screen and I'm like, I can't read any of that. So if you see me turning around, that's what's going on, which is super ironic for the eye doctor. Actually, I can actually read the screen from here. So, the genetics of this I saw was covered earlier. Oh yeah, look at this. Yeah, now we're moving up in the world. So, thank you. I just have 4 of these coming in today by UPS. So, very similar to a lot of inherited retinal diseases. A lot of the mutations in this disease are the first ones. Here, it's about 20%. When you look at inherited retinal disease, it's like retinitis pigmentosus. It's about 80% are de novo mutations, but still, oftentimes we are looking for families and we know who has it, and then we start screening relevant family members. But a lot of my patients have no known family history, and then they present late when they become symptomatic, and oftentimes their only manifestation is in the eye. It's a relatively uncommon or rare disease, about 1 in 35 to 1 in 40,000 live births. And by and large, the lesions aren't present at birth, although we don't universally screen newborn babies. So the only way that we can actually tell, we used to think that retinal blastoma, most common primary malignancy in children, wasn't actually present at birth. It present around 10 to 12 months. But when you actually start looking at families at birth, you can actually see the lesions are present. And we're starting to see this in many other diseases. So it remains to be determined if, in fact, there are patients who do not actually have congenital manifestations in the eye. And there are universal newborn screening programs going on, most famously in China, but we'll start getting data coming soon in the United States. Typically, patients become symptomatic in the eye around 20 to 30 years, but as we'll talk, screening should begin much earlier. And for my part, even though brain and kidneys and all those other organs are very important, I'm very much interested in the eye and particularly the retina. So Ocular involvement ranges, anywhere from 50 to 70% of patients. And it tends to become more as you screen later in life because of the way the growth factors are elaborated in the eye. And we'll talk about that in a second. That can cause new lesions to form over time, which is not uncommon. The eye is often the first case where we say first to be involved, but I think more often it's the first to be discovered, and it might be you may become symptomatic in the eye first, and then when we look at young children or those less than 10 years of age, up to 5% of these kids will actually have it. I have a couple of patients where they've presented below age 5, but by and large, I pick up the lesions around 15 to 18 years of age. Bilateral disease is common. Usually one eye is more severely affected than the other eye, and we're very thankful for that. And then, whether you're on the pheochromocytoma side or not, it from the ocular viewpoint, the lesions tend to be occurring in both subtypes. Basically, growth factors are, wow, that's better. Maybe if I just hold it closer. I'm an eye doctor, not, well, I am an engineer also, so who knows? So, the growth factors occur in response to insult, okay, in addition to during the normal course of pathology. And we don't actually know what's causing the localized retina insult that will result in hypoxia or lack of oxygen to form. But then what happens is the body starts elaborating hypoxia inducible factor, PDGF, vascular endothelial growth factor, and all of these things are basically telling the retina, hey, I'm under insult, please help me. And the only response to that is to build new blood vessels, or in these cases, new blood vessel nests of tumors, which we call hemangioblastomas, or in the retina community, we call them angiomas. And these can start off as tiny little red dots. And if you're not really paying attention to these tiny little red dots, you may say, oh, it's just like a hemorrhage or like a tiny microaneurysm. But if you follow these things over time, they actually develop three dimensionality and will grow into what is commonly identified as one of these tumors. And these tumors have a very characteristic presentation. You have a draining vessel and a feeder vessel, and they're very fat and tortuous. So we call that dilated, and tortuous just meaning like a corkscrew. And then, of course, in the center here, you have your capillary hemangioma, hemangioblastoma. And this is pretty advanced, okay? That is not an easy lesion to treat. And when you do treat it, you're likely to have some side effects, which are not happiness based on where this is located. There's two important structures in the eye. One is the center of your vision. We call that the macula fovea, okay? And then the other one is your optic nerve. And so the way I like to think of it for the older people in the room, the retina is the film of the eye, okay? For the younger people, it's your iPhone screen, okay? And then for the way to connect the retina to the brain, we have a cord, and it's called the optic nerve, okay? And if you cut the cord, it's game over. It's like a spinal cord injury. Nothing is going to help you today. And so we want to protect the nerve at all costs. So nerve number one and the retina number two. And when you're really looking at the retina, you want to protect this 350 micron spot. And that is what allows you to see 20/20 or 20/10. Okay. I'm willing to sacrifice pretty much all of your retina, okay, to save everything else, because then I can keep you reading, and you may end up with tunnel vision, but I can keep you reading and potentially keep you driving and able to recognize your family members, loved ones, grandkids, or what have you. Okay. Now, very uncommon for lesions to occur in the fovea macula. Okay. This is a bad lesion. It's a lesion that's on the optic nerve head, and we'll talk about where the locations go. But this happens about 10% of the time, and there's no easy way to treat these lesions. And the reason for that is that if I treat the lesion, I kill the nerve, and then that's bad because you can go from 20/20 to no light perception, which is basically what everybody in the room equates with blindness, meaning that it's black. Normally, we don't talk about blindness as being black because usually we think in terms of legal blindness, vision of 2200, or a visual field of less than 10 degrees. But here it's what you guys are thinking about, which is you see nothing in the eye. And so most of the treatments that we aim to treat this lesion when it's located near the optic nerve are going to result in damage to the optic nerve. And the downside here is this lesion can be huge and your vision can be 20/20. Okay. And the bigger I let that lesion get, the worse your ultimate outcome is going to be. But the second I do anything to treat this lesion, you're going to lose vision immediately. Now, it may not be 100%, okay, but I can guarantee you, you will be unhappy, and we'll have a lot of unhappy and sad conversations about this. So when I see lesions like anywhere around the optic nerve, I get very concerned, and our general policy is to observe them and allow them to grow over time, which is why many of us are excited about new pharmacologic approaches to these diseases that could potentially take care of these on the side as a bonus side effect. And we're looking at our patients. So the capillary hemangioma or retinal angioma, or however you want to talk about it, hemangioblastoma, this thing's very sensitive to location. Um, they can occur multiply, and I see this in about half of my patients. And all of these are active. They've been going on for a while. This is an unusual lesion. It's very close to the center of the macula. These are more classical, where they're distributed in the periphery. And what you want to do is make them go away, right? And we'll talk about how we make them go away in a second. One thing that can happen is they can spontaneously resolve. This is what we're always hoping for when it's on the optic nerve. It almost never happens in my experience, but it could. The other things that are bad, the number one bad thing is exudation, which, when these are just basically tumors comprised entirely of blood vessels, if you want to think about it like that, and they leak when you poke them. Okay. And so if you poke them with a treatment, or like a freezing treatment, or a cutting treatment, or a heating treatment, or a radiation treatment, or a laser treatment, they leak. And that leaking is almost certainly worse than the lesion itself, because we don't have any good treatment. And then on top of that, it tends to send out lipid, fat tissue, and that lipid is toxic to your retina. We have no way to get rid of that. Okay. So, what we want to do is treat these lesions when they are unlikely to leak. Okay. Bleeding, that's bad, but we can deal with it. Exudative retinal detachment, which is, retinal detachments come in three flavors. Think of the wallpaper on your eye. If you cut a hole in the wallpaper, we call that a regmatogenous retinal detachment. That can happen if I'm cutting on your retina to treat these lesions. The second most common form is exudative, which is kind of like a frog's neck where it blows out, okay? And it's just fluid is accumulating under the retina, but there's no hole. And then the third kind is tractional detachment, which is very common in this disease. The air in this room in your eye is jelly, okay? Think of it as like grape jelly, and it's relatively clear. But when these lesions are leaking, proteins and exudate and lipid goes into it, and it starts to contract, and it pulls on my retina, and it's trying to pull my retina off the wallpaper. And the way to treat that is to cut the adhesion, and then my shirt falls back down, and hopefully your retina goes back to where it was. Okay. All three of these retinal detachments occur in patients with von Hippel-Lindau, and you can pull so hard on the retina that it can actually induce a regmatogenous retinal detachment. This is someone who's been advanced disease, discovered late, and poorly responsive to therapy, you form blood vessels in the front of the eye from all the growth factors that are in there. And then the pressure goes shooting up, and the eye becomes blind and painful. And we can't do much about it because it kills the nerve, and then we lose the treatment. And so, what we want to do is avoid two things on this page: the exudation and the neovascular glaucoma. Everything else we have good approaches for. Spontaneous resolution, I can think of one case where this happened and was only like in one eye, and in one lesion of one eye. And I didn't actually believe that the patient had von Hippel-Lindau, but the genetics were very definite. So they just had a very mild retinal phenotype, meaning that the way it presented in the retina, and then the lesion just died on its own. And that's great, but it's not the normal course, okay? In this case, it was published, this one resolved after 4 months. I would have been hesitant to observe this because those yellow spots are exudate, and this here is fluid, and that's the center of your vision. So this patient would have presented with distortion, decreased vision, and maybe a decrease in peripheral vision at the same time. And the longer that is sitting there, the longer your brain is underwater or your retina is underwater, the less likely it is to work as it used to work. And so that's why we're sitting there. This is really advanced lipid exudate from Larry Annuzzi at the Macula Center in New York. And this is a poor outcome with a still very active lesion, but the feeder vessels are, what do you call it? The feeder and drainer vessels are no longer tortuous and dilated, which means that at some point this was under control, but it still shows activity. And it's saying, I'm very angry at you for poking me, Dr. Yanuzzi, so I'm going to put lipid everywhere in the eye. So, the exudate and hemorrhage, again, this is what we see all the time, where you've got multiple smaller lesions down here. This eye has not been treated, and the lesion is continuing to just leak on its own accord. And unfortunately, this leakage has a propensity to go to the most gravitationally dependent place in the eye, which is the center of your vision, which results in lipid and fluid accumulating in the center of your vision with poor outcome. Again, large lesions. The difficulty with large lesions, and we're going to be getting into treatment here shortly, is that when you're treating it, you can only get the surface treated. Okay, so you may like cook the surface of the tumor, but you can't get into the core of this blood vessel tumor, and that results in the lesion continuing to have, activity. This is a tractional retinal detachment in a young person, and these areas that look white are actually where the vitreous inside the eye is. There's fibrotic tissue growing through the vitreous jelly. So it's kind of like, here's where your tumor is, but somehow it's kind of growing into this plane. And that is a bad finding because it means that the lesion's been there a while and it's trying to kind of grow and expand on its own and find new places to go. It's not a metastasis because these aren't malignant lesions, but it's behaving in a manner that's going to be bad for the eye. When we look at screening, now that we know what these lesions look like, we want to identify these lesions well before they get to this size. We start screening usually, at diagnosis. If we know that they have it, the recommendation is at 1 year and then every 6 to 12 months, beginning after 1 year of age in patients with known disease. If the disease has been very stable for a long time, inactive, and the lesions are burned out, I like to see the patients annually. If I'm in a situation where patients have been receiving any treatment, I see them at a minimum of every 3 months until I can get them to a couple of years of disease inactivity. So the first year I'll see them quarterly for 3 months. Then the second year, if they're still inactive, I'll get it down to every 6 months. And then on year 3, I'll start thinking about stretching them out to annual. I do not trust my own vision looking at these children or young adults or even older adults with von Hippel-Lindau. Our standard practice is to use 180-degree wide-angle imaging, which is, you've all seen it, it's the Optos wide-angle camera. And then we don't even rely on that. We actually have 5 views, optic nerve centered, up, down, left, and right. And we sweep, and then we look at all the photographs, and then we compare the lesions for disease activity. And then on top of that, we'll do red-free fundus photographs, because sometimes the lesions show up better in a non-color fundus photograph appearance. And oftentimes we will also get autofluorescence, which will highlight earlier lesions. And so that objective data is very useful for us, and it's way better than someone looking at your eye up, down, left, and right. I can miss a very large lesion doing that, even if you get momentarily distracted. But these photographs have been a game changer in our ability to manage these lesions. So treatment, observation, mainly limited in my practice to peripapillary or optic nerve lesions. And that's just because anything I'm going to do is going to result in a worse outcome. Laser is my treatment of choice. We'll come back to that in a second. Cryotherapy, I'm not a big fan of, but it works in larger lesions. Intravitreal injection of anti-VEGF therapy, the vascular endothelial growth factor inhibitors, you're losing at this point, okay? And I'll talk about that in a second. Radiotherapy is also good for a lesion that you might consider cryotherapy on. And then surgical treatment, again, you're losing. So what I like to do, small lesions up to maybe 1 to 3 millimeters in total thickness, I want to hit those with laser. You want a nice, long, slow burn, so something between 500 milliwatts up to a second, 500 milliseconds up to a second, with low power, so you don't create actual bleeding on the surface of the lesion. And again, you don't want to have an aggressive insult to the tumor, because it will leak fluid and give you lipid, both of which are bad, okay? So the slower you can cook the lesion, and even if it has to happen in multiple sessions, the greater your likelihood of control without bad side effects, okay? My job here is not to kill the tumor. My job is to kill the tumor and preserve your vision, okay? Those are the two things. And so that's why I don't like cryotherapy, but sometimes you don't have a choice. You have a lesion that looks like it's the size of a robin's egg inside the eye. Laser is going to do nothing to that, okay? Freezing therapy may approach it, and you can go in there and maybe initiate a good involution, meaning causing the tumor to die, but it is going to give you a horrific inflammatory and exudative response. And that is going to cause all sorts of bad things to happen to your eye from a vision perspective. You know, it's kind of a classic situation of where you win the battle, but you lose the war. Okay. And so I can kill the tumor, but you might lose vision. And so I do not like that. I do like intravitreal injections sometimes on these larger lesions, because they got to this size. Now they're elaborating a whole bunch of growth factors. It can predispose to that neovascular glaucoma, where it forms blood vessels in the front of the eye. And at that point, it's your optic nerves at threat. These VEGF inhibitors are spectacularly effective. Okay, they will shut down all the VEGF production in that eye for a little while. What's a little while? 2 weeks to 4 weeks, okay? But if I can keep the eye in place for that, I have some patients where I'm injecting them on that sort of frequency forever, okay? Other patients, you get them past the hard time, and then you're able to initiate a more therapeutically permanent outcome. And so another area is radiation for these larger lesions. I've occasionally sent patients off for radiation. I don't like it in general, but again, sometimes you're up against it. What I do like about radiation is that it's not going to induce the inflammatory response that I see with, sorry about that, that I see with cryotherapy, but it introduces a different problem. And the amount of volume of your retina that's exposed to the radiation will predispose you to a longer term complication called radiation retinopathy, which can be characterized by all of the findings and complications that are typically associated with these lesions. And so, in a kind of compromised retina already, I am very hesitant to really proceed with radiation unless I really have no other option. Surgery, I tend to reserve that for the retinal detachments. And sometimes when I'm in the eye, I will excise a lesion, and it's useful. And it doesn't mean that they won't come back. So what you have to do there is you basically cut off the feeder vessel and the dilating vessel, and then you actually physically excise the lesion. It can result in permanent visual field deficit in that eye. So you have to be very careful where you're looking at it. Again, basically treatment's decided on where the lesion's located and how big the lesion is. I do use a lot of intravitreal anti-VEGF in peripapillary lesions. It does not seem to slow the growth of the lesion, but it occasionally will take care of the lipid exudate. Sometimes we'll add steroids on when the eye is really leaking. And sometimes your physician will come up to you and say, hey, I want to inject a steroid into your eye before I laser, or before I treat you, in order to blunt that leakage response. The downside of injections of steroids is that they can induce, I'll be quick here, don't worry. They can induce cataract and glaucoma, but they're both manageable. So this is what you want to see. You have an active lesion here, you hit it with the laser, 3 months later, comes back dead, okay? Now, when we're following these, what we're looking for on this thing is, if it's been like this forever, if you ever see a little spot of blood there, it's kind of like a tree that's been hit by lightning and it's dead. And then a couple years later, you see a couple leaves growing off of it. We don't like the leaves, okay? So if we see the leaves growing off of it again, we'll go back and hit it again. And so you always have to inspect those areas very carefully. Again, this one, it was a magnificent outcome. And then, it was all well treated, but then they got recurrence right there, those leaves coming back. And that is not at all unexpected following cryotherapy and or laser therapy, because this is a large lesion. It's probably 5 to 7 millimeters in thickness. Very difficult to destroy the entire contents of that lesion with some sort of cytodestructive therapy. Surgical therapy, again, this is a patient that we showed earlier pre-op, and we had these tractional vectors come in. We went in, we relieved those tractional vectors. The retina is very edematous here, but still has this active lesion right there, and then an area of kind of telangiectatic change, possible early lesions. And this was published a few years ago. And so what we've learned on these earlier lesions, once you get this sign that you're growing into the vitreous, you have to be very aggressive. If they have this vitreous phenotype where it wants to grow in there, because the longer that thing grows and is left unattended, the more complex your retinal detachment is going to be, the less likely you're going to get the retinal angioma control, and the more likely you're going to have a vision deficit. So, in conclusion, the single biggest thing that I can do for you is to bring you in often and start screening you from the beginning to identify the smallest possible lesions. All of these lesions that you saw on this presentation are lesions, often in patients who are either the first one in their family or they've been completely asymptomatic or have had no access to screening. And by the time they finally presented, they had lesions that were of a large size. And once we have family members, it's really spectacularly satisfying to identify these really tiny lesions and just treat them every time they pop up because they're very responsive to laser therapy. And so there's the one thing I can tell you is don't miss your eye appointments because they're very useful and the more you have early, the less you'll end up having in the long run. And so I'll open the floor for any questions or anything, and then I'll probably get hooked out of here because I'm over time.
Okay, so I see an optometrist who has an Optos machine, and then I go to the Eye Institute if I need to have a procedure. How do I explain to her leaves, or is that a good way to explain?
Basically, they know what the lesion looks like, okay? And so if there's any change on the lesion over time, that's an indication that you should be referred back to the treater. Because what I do is I just put the two photos up side by side. Humans are spectacular at pattern recognition. We can identify 10 micron changes over time, even on sequential imaging. And so as long as you have the same photo of the same location, any difference is likely real or artifact. And so that requires a referral to the specialist.
Thank you.
Yes.
Hey, thank you. We went to a doctor who was hesitant to dilate her eyes because they said it wasn't necessary, that they could see just fine. Can you?
So, in general, you need a dilated examination here. Now, the exception would be as if you're getting the wide angle Optos photographs, because those could be done in a what we call non-mydriatic fashion. It's because it's not using a traditional light camera. It's using a scanning mechanism. So it can go through a small pupil, but for confirmatory purposes, oftentimes you're going to still, these cameras, because of the way they scan, introduce a lot of artifacts. So it's insufficient to just rely on the camera. You should have a dilated exam. Now, having said that, I'm a pediatric retina specialist by training. And when you have a kid between the ages of 24 months and 6 years of age, and if you go and put dilating drops in them, you're never going to examine them without anesthesia. And so we will often try to get them to come in and just do the Optos during that time, which is great. It's been a complete paradigm shift for how we deal with these young kids, because otherwise we used to bring them in for anesthesia several times a year just to look at their eyes. Steve's eager to get rid of me.
Great. Okay. Thank you so much, Dr.
No,
Moshfeghi.
listen,
Appreciate it.
my pleasure. And I will leave. Yeah, there you go. Perfect.
The ophthalmologists always have the best pictures, most colorful pictures.